It's my pleasure to introduce to you today Marcio Sotero. Marcio is one of our pediatric epilepsy and pediatric neurology colleagues here at Swedish. Marcio trained in medical school at the State University of he did 2 pediatric fellowships, one in Loyola in Chicago, went on to do pediatric neurology at Mass General in Boston, and then an epilepsy fellowship at Children's Hospital in Boston. Marcio is an outstanding colleague for us here today, and he's going to talk to us about the very unique mechanisms and hemiplegic issues in children. Marcio, thank you.
Thank you. I'm going to start with a couple case. One is one of my patients. So this patient was born after uncomplicated pregnancy, labor and delivery from healthy parents. Mild motor delay and language development. And right after birth, the patient started having some funny eye movements and started having some and those eye movements were very very funny. One of the eyes would beat one side and then to the other one, and okay. I was in the wrong case. She was born at term, and so this is the first day of life of that patient, and described with a jerky motion of the eyes while sleeping. They'll last for a few seconds, and the nystagmus again one. Was taken to the NICU. The parents were in the service, so they were taken to a hospital in Germany. They were in Europe already for the army. And the doctors in Germany were a little baffled about that. Go to the United States and did a metabolic workup, did the EEG again, that was all negative. Everything they done in Germany, they did again in the US. And then finally, the doc did an LP, EEG, EKG, repeated the method. I said, oh, let's do a genetic testing on this. And sure enough, it found a mutation on this gene, ATP1A3. I'm sorry, I gotta go back here. And the second case, which is about a patient born after uncompleted delay, low tone, and then at age 4 had mild trauma on the forehead, which means bonk the head, which happens all the time with 4-year-olds. Then after the episode, the patient was mute, would converge, so like a convergence pass, and the patient couldn't walk. And over several hours, the patient started to have some dystonia from the hypotonia and developed some mutism. So the patient basically, and when he started he talked with the dysarthria and there was a lot of drooling. And again, like the other kid that presented as a newborn, there's a bunch of tests and metabolic tests. And this kid was in Boston at the Beth Israel, and I trained there. So they did a lot of like metabolic tests, everything known to man, and didn't find anything. They even checked the spinal fluid for neurotransmitters, and everything looked normal. They did a PET scan, Let's try bye. So the patient became stable over several months, and they had mild improvement, and but the dystonia was still there, a little bit less prominent, and for several hours, and then it would become stiff. And obviously, the doctors tried several things, trying to give L-DOPA, especially, which is a common thing so in pediatrics, the tone. And they did the usual treatment for people with dystonia in pediatrics with dopamine agonists and anticholinergic medication. But the patient didn't respond very much. And a lot of the dystonia was in this area, and there was significant swallowing difficulty. And then they did a test that showed an abnormality on the same gene, but instead of the protein liking exactly what the mutation was from the other one, this one was back here. So this is what I wanted to talk to you guys about alternating hemiplegia, which is the baby story, and the second one is even though he was a kid, alternating of a rapid onset dystonia Parkinsonism. The case that has the dystonia and presented that like in the first few years of life, it's atypical. So because this was designed mostly for adults at this talk, so we're going to talk first about rapid onset dystonia Parkinsonism, which we abbreviate with and the person who named probably was a pediatrician. So RDP, not RODP. But the movement disorder people like to call everything with dystonia is DYT and put the number, and so this one is DYT, rare hemiplegia, and I just want to keep my time. And onset between 10 to 30 years old, but wide range and most of the people and they usually, the typical thing is that the patient has a trigger that's usually a mild trauma, physical stress, exercise. The trauma usually not that. And the other thing that's very typical is this topographical gradient with face more than arm more than leg, and prominent bulbar involvement like that patient had. Now, I'm not sure if you remember when I told you about that kid, even though it was a kid, the typical progression is for the bulbar involvement to present. So this, these patients having Parkinsonism too, with mostly bradykinesia and truncal stability. Feature are the lack of tremor, which apparently you can have that in regular Parkinson too. But the poor response to L-DOPA, or the complete lack of response to dopaminergic agents, is also typical for those, and not typical Parkinson. So hypotonia, cognitive impairment is common. Rarely you can have psychosis. Seizures are pretty rare in this in these patients. The criteria are those that you're reading there, which is of the clinical symptoms, but they wanted to do a set of criteria, and I think those were made when they started again the DNA testing. Dr. Brett Scher is one of the for a long time on this disease. And seizures are rare, as I mentioned, And the mutations on the ATP1A3 gene are those that are more common. And we'll talk a little bit more about the mutation in the gene a little later. So the A3 causes dystonia, and we always like, oh, how does that work? Because this gene doesn't manifest very much on the nigrous striatal neurons. And so everybody always don't have a great reason for it, but ATP1A3 helps the dopamine reuptake, and also acts on the other side of your movement disorder balance, right? So in epilepsy, you go action inhibition, and with the excitatory neurotransmitter movement disorder, people always have the GABAergic versus the dopaminergic system here, and definitely this has been shown over and over in the rats that a lot of the dystonia and that little ataxia in the rats is related to the impairment of the GABAergic neurons in the mice. Not rats, I'm sorry, mice. The differential diagnosis, which is also goes back to the physiopathology, starts with disorders of dopamine biosynthesis. One of the main ones is dystonia with that is a seizures, and a few mutations cause even status epilepticus. The eye movements are kind of funky. They are nystagmus, and not many things in neurology gives you uniocular nystagmus, so meaning like the left eye is looking forward and the right eye is beating point, point, point. The nystagmus may be in any direction, and I guess people pick up more the horizontal, but it could be in any direction. And it can look like the 1.5 syndrome of Miller-Fisher, because one eye may be looking forward, the other one may be beating. And you may have a few other funky eye movement disorders, strabismus, esotropia, exotropia, so it may look in, out. You can have like paroxysmal eye deviation that looks like an ocular gyrate crisis. And ocular motor apraxia is also common. And a lot of the patients with ocular motor apraxia, they can move the eyes in all directions, but when you ask them, or when they try to track something, they have to turn the head. That's ocular motor apraxia. So episodes of weakness and alternating hemiplegia, that's what gives the name to the syndrome. I guess that's what the first researchers, especially Dr. Accardi, who kind of defined the syndrome with a little more detail. Dr. Accardi was the father of child neurology in France, and after a while in the whole world, one of the great names in child neurology. So episodes of weakness, they can be hemiplegia, as the name suggests. It can be bilateral, so quadriparesis, and sometimes the patient is not totally plegic. They may become weak, hypotonic, and then dystonia on top of that. That's also not unusual. They usually start before age 6 months, and the frequency is variable. And a lot of the parents gauge the severity of the disease from the hemiplegia. And the classic thing is sleep relieves the weakness. And if you make the person sleep, usually they wake up a little stronger or completely normal. Like the rapid onset dystonia Parkinsonism, the people oftentimes have triggers. Triggers in kids are a little different because kids are different and they're exposed to different things, but bright light, excessive heat or cold, noise, but again, mild head trauma is another one. Missed meals like seizures, so hypoglycemia, and extreme or atypical exercise can cause that, illness, and irregular sleep. So movement disorder on those, and those patients can have, so because a lot of us that follow those are epileptologists, after a while we had like one of the movement disorder specialists kind of analyze a lot of the movements, and now we have in our society more movement disorder specialists. And so when they film those guys, they have a lot of chorea and dystonia, and in third place came chorioatetosis. And when they get older, even though this ataxia here is last on the list, but as the patients get older, ataxia is something that you can see in the phenotype. And they have tonic and dystonic attacks. And I have a funny story for the epilepsy specialist. We had like some guy, 96, 97, I don't know. We had like a meeting here in Seattle for the Hemiplegia Foundation, and we invited some guy from Italy, Dr. Vajavano, and he put the movie of a patient, and there was like 5 of the top pediatric epilepsy persons in the US at that time. And they look at the movie, and Dr. Vijayavanu said, seizure or no seizure? And of course, they all got wrong. Everybody thought the patient was having a seizure. The eyes were beating to one side of the body was totally stiff, and all the epilepsy guys like, poor seizure, man. And what's this Italian guy coming here trying to teach yourself, and they're all wrong. It was all hemiplegic attack from alternating hemiplegia. So it can be disconcerting and can give you a run for the money. So we do a lot of EEGs on those patients. And I've had my share of patients like that. Movement disorder is still hyperkinetic as a general rule. They can have a little bit of myoclonus, and deterioration can be seen 25%, and that mutation, the E815, can be associated with a more severe phenotype, which is confusing because that's a mutation has a lot of status epilepticus too. So the diagnostic criteria I put here just for completeness sake, but it's a repetition of what we already discussed. Those are called the ACARD criteria because he developed that, or Paris, that's because they develop over there. Differential diagnosis is a little hard, so that's when being a child neurologist is helpful because that stuff, if you're not a child neurology specialist, you haven't heard a lot, but a lot of metabolic disorders. And so the muscle people usually heard about Mellis, the epilepsy people heard Mellis and Murph. So the mitochondrial disorder associated with some muscle weakness and lactic acidosis and myoclonic seizures. You may want to do an MRI with an spectroscopy to diagnose those guys, check lactate during the events. Mutations of the calcium channel can look a little bit like that. In patients with various disease like moya can have fragments of these symptoms, and again, seizures can be part of it or can be on the differential of it. So seizures are common on those guys. Some people in our group think that maybe Japanese nationals are a little bit more prone to it. But other than that, you can just say that about half of the people will have seizures. They can present with seizures first, and then you see the hemiplegic attacks. Or the hemiplegic attacks can precede the seizures. Like in that first case that I showed the baby, the plegic attack started first. The seizures can be so bad, but so bad as a baby that you call them in the special category of epilepsy that we call encephalopathic epilepsy or early developmental encephalopathic epilepsy. And again, rapid onset dystonia Parkinsonism can have easy to treat seizures. And several series of patients with epilepsy and alternating hemiplegia may present with a seizure after having a serious plegic attack. Lots of behavioral problems are common in those patients, especially over time. And it's the usual things that you see in pediatrics: attention deficit disorder, expressive and receptive language, executive dysfunction that comes hand in hand with ADHD, and hyperarousal symptoms, which many times they're just talking about hyperactivity. So the usual conundrum that you see in epilepsy and neurodevelopmental disorders. So people may progress over time, and that's when things get a little more confusing, and that's when you start to think about, that makes sense that they're the same gene, because over time, people may have fixed dystonia, they may have corticospinal tract, and you can even see some fragments of Parkinsonism in those children. And then you say, oh, now it makes sense that they have the same gene that causes Parkinsonism, and maybe we are a little too focused and overwhelmed by the hemiplegic attacks, and we did not pay as much attention on some of this Parkinsonism. Those guys can have lots of cardiac stuff. That's another overlook problem. And it becomes like Rett syndrome, for example, where you have to have some guidelines to just do EKG on everybody because they have those death attacks, as they call them. It's like they can have like fatal arrhythmia sometimes. So you may want to survey them with echocardiogram periodically, once a year at least. About 3% of the people end up needing pacing, according to one of the people who looked at the cardiac problems. You can have a little bit of atrophy on the MRI, but usually the MRI is not diagnostic. And diagnostic is this gene, and I would like to spend just like some 5-10 minutes talking about this gene. About 90% of the people with alternating hemiplegia will have a mutation on the ATP1A3. The cousin gene, which is the ATP1A2, may have alternating hemiplegia, but more often has hemiplegic migraine. And if you have the same syndrome and the DNA testing is negative, you have a better prognosis. And as I mentioned to you, because my bias was first learning about alternating hemiplegia, then RDP, when we came across this gene in the early 2000s, we realized that people with movement disorder world knew already about this gene, and they knew about RDP. So the ATPase is the one that you learn in medical school and we keep hearing about it if you're an epileptologist about that, because that's the enzyme that kind of reconstitutes the membrane potential after you have action potential. But why is ATP1A3 is because it's a subunit of that enzyme. And the enzyme, if you kind of open that all the way up, you see those 10 domains here, right? And this is the alpha subunit opened up, and this is the beta subunit here. So ATP1A3 for alpha subunit. There's 3 versions of it, and the one that's altered in alternating hemiplegia and RDP is the 3. In rare cases, you can have the 2. Those are the places where it manifests in the brain. Again, as I mentioned, the GABAergic neurons. And the other thing that I didn't mention that's kind of funky for movement disorder people is that this subunit interacts with alpha-synuclein, the one that would disorder with Parkinson with what's it? Lewy body disease. Yes, that's what. Lewy body disease and Parkinson, and that's been associated with the cognitive dysfunction of that, and so that is very funky. It also interacts with the beta amyloid, the same site on alpha-3 and the extracellular domain of the protein. So a lot of people say, yeah, maybe this is where you have this cognitive or cognitive dysfunction from. And again, as I mentioned, it also alters the reuptake of dopamine when it's dysfunctional. So this is the ATPase. So the ATPase lets 3 sodiums in and then closes this channel here. And there's a little channel here that you're not seeing that lets the sodium out and then lets 2 potassium molecules in, and usually a hydrogen goes in. Potassium is a little bit bigger than sodium, so there's usually don't fit on the 3rd site, which is this baby here, and that's where the proton goes. This is how the enzyme really looks. And this is my little drawing here that shows this. There's a channel here in the protein, and then first the sodium goes in, takes this place here, and then this channel closes, this channel opens, lets sodium out, 2 potassium in, one proton in, and mutations on this site here can cause a lot of problems. Same thing for those 2 first sites. So the ion binding sites are numbered 1, 2, and 3. 3 is the hybrid one, sodium and proton. The 1 and 2 was just the ones for sodium and potassium. again, most of the mutations are on those axons here for the alternating hemiplegia, where you see the clustering, and they encode for those transmembrane domains here, and they're not exclusively there, but they're mostly there. And then, the alternating hemiplegia are the blue dots here. The red are the, the alternating hemiplegia are the red dots. The blue dots are for the rapid onset dystonia Parkinsonism. This is the Japanese group showing that they have the same clustering here on the transmembrane domains 5, 6, and 7, and a little bit on 8. This is the American, and some of Dr. Violet got some of the people that donated DNA for our group here in the US. Most of the mutations are missense, and there are 3 mutations that are more common in alternating hemiplegia, and RDP are a little bit more widespread. So Dr. Heisen from Germany mapped those. So this is the gene number. So RDP tends to be a little bit more diffuse, and alternating hemiplegia a little bit more clustered. And this is the Chinese group showing the same thing, but this is color-coded for showing the distance between the iron binding and where the mutation is on the protein. And this is a frequency. Those are the 3 most common mutations. Those mutations, this guy here is associated with a lot of epilepsy, status epilepticus. This is just the most common mutation, and this is the more mild mutation. And we talked about that, so I'm gonna skip that. Inheritance is when you have it, most of the alternating hemiplegia are de novo mutations. The RDP can have more familial cases. The familial cases tend to be dominant, and with a little bit of variance in the penetrance, meaning not everybody that has the mutation will develop disease. That's what penetrance means. Few families are seen, and you can have germline mutations, which means like you can have more than one case in the family, even though the parents' DNA doesn't show abnormality unless you get DNAs from gonadal cells, right? There are a few allelic conditions, and I'm going to try to talk a little bit about some of them. One of them is Kapo's cerebellar ataxia with pes cavus and optic atrophy and sensory neural hearing loss. Those things are made to sound the way that you can remember, but the pes cavus is more variable, even though it comes second on the list there. And cerebellar ataxia, optic atrophy, and the hearing loss are a little bit more common. And the mutation tends to be always the same. And obviously, when you don't have pes cavus, they have to invent a new name, and they put chaos or chaos. And whenever I read that, I always remember about Agent 86 Maxwell Smart, because the enemies of the Maxwell Smart was the Chaos Agency. But this chaos with a C. And they do have recurrent cerebellar ataxia. So when you don't have any of those things, only recurrent ataxia, they had to invent a new name. Is recurrent encephalopathy with cerebellar ataxia, or RECA. And then, of course, there's the variant of the variant described by a couple people in Chicago, which is encephalopathy with a recurrent triggered by fever. And again, I mentioned to you guys that you can have epileptic encephalopathy, so early onset seizures that are very hard, a lot of infantile spasms on those kids. And it's just a little bit different presentation. They don't get better with anything. They develop microcephaly, and they have prolonged episodes of apnea, severe developmental delay. And Dr. Dobbins and his group described that some of those patients actually have polymicrogyria. So yet one more thing in pediatric epilepsy that has a lot of seizures, has a mutation, but it can have brain MRI abnormalities. By the way, this thing here can be caused also by the ATP1A2, the one that usually causes hemiplegic migraine, which is, again, another dimorphic thing in child neurology that can have a mild presentation or more severe. Treatment, you make them sleep, the abortive treatment. People used to use gamma hydroxybutyrate for that. It's very hard to get that. Unfortunately, this is a drug used for date rape. So the FBI and all the agencies are really, really, really tight in observing prescription for that. So it's kind of complicated to get that, obviously, but it's something a lot of the parents like because it produces very fast sleep. Usually we use medications for seizures like nasal-midazolam, nasal-diazepam to induce sleep. And oftentimes you have to be varying because they use a lot of that. Dystonia is very challenging. Every time we have a meeting, we have the movement disorder specialist weigh in, but it's hard, man. It's just, they all say, hey, treating dystonia is hard in general movement disorder practice, but this is even harder. And that's what you hear about, or we call them, say, dude, can you help me with this? But it is hard. There are a few weird things that people do. Some people respond to diphenhydramines or Benadryl. And some of the movement disorder people like to use clonazepam, PRN, and regularly. But oftentimes you have to use the same trick for the plegic attacks, make them fall asleep. Weird stuff that's preventive, flunarizine. This is a Canadian drug. Well, it's a drug that's everywhere but the United States. It's a dirty sodium channel blocker, very used in Canada for migraines in pediatrics. And it does decrease a little bit some of that. The plegic attacks, some people like to use the ketogenic diet. Topiramate, an MDA receptor blocker, amantadine, and now people have been using memantine for some of those patients. I don't use a lot of steroids because of a lot of complications, but some people have used. Beta blockers too, I haven't used, but some groups have used that. Haloperidol and aripiprazole, obviously it's very complicated to use that because they can cause dystonia themselves. And CBD for mostly anxiety and other stuff that I put there on the mix, just related to the apnea, the CPAP, BiPAP, and then just because it's never enough so that you don't forget, as your last thing is avoid triggers and do your cardiac evaluations. So for that, I'll leave a couple minutes for, have any questions? If not, we can.
Any DBS used for this?
Yeah, people have used the movement disorder specialists say, hey, man, we have failed that sometimes, but they have said, oh, yeah, you can, yeah, not very, the last meeting about 2 months ago, we discussed some of that. And the team from California said, yeah, we used it a few times and didn't get great success.
Marcio, the stimulations that triggered for originating hemiplegia seemed a lot like some of the sensory things that, say, autism kids can have. Is there anything overlap with autism?
Yeah, I didn't mention. A lot of those people, it's like a lot of epileptic syndrome. They have autism, and the parents all say, hey, man, this autism is a little different from the usual. So the question was, a lot of those symptoms are very similar for the autism patients and some of the stereotypies. Do they have autism? Is there any overlap? Yes, there is overlap. The autism tends to be very atypical in those patients, like you see in SCN1A, for example. All the parents of the SCN1A patients, when they get diagnosed with autism, they say, yeah, it's a little different, right, doc? And it's like, yeah, it's always different a little. But yeah, they have a lot of overlap with the autism and with the sensory stimulation that the autistic kids do. But it's just a little different, and we haven't found an angle to treat that, which is obviously our desperation, which I always try to seek in. Is anything we can inhibit? But no, the only the wisdom for the past 25 or more years I've been following that is just like, you have to make them sleep. The new thing is an MDA blockers. So, and the calcium channel blocker was discovered way back when, and we still use that. So those are the things that we do. We try to say the same thing we say for people with seizures in terms of avoidance. We say, hey, avoid hypoglycemia, avoid sleep deprivation, avoid dehydration, and that helps a little bit. But sometimes you said all that, you have those great parents, and then the kid trips and bonks the head. And since they are a little ataxic, that happens pretty frequently, and that's frustrating.
Marcio, are you aware of anything, any data that suggests using something like modafinil worsens it, something that helps with keeping people awake? Have you ever seen anything where there's a provocative nature to arousal drug?
I have not, man, and we do use a fair amount of medication for attention in some of those guys without much problems at all. I guess it's the same thing as people with epilepsy. We use that, and if they have a seizure, we still overwhelm them with a GABAergic agent and make them sleep. So usually it doesn't trump that. But yeah, that's the thing that we still do. But no, yeah, we use that.
What's your kind of streamlined method of doing genetic evaluations for these patients?
Well, most of the people, they get a specific test still. Some of the genetic companies are coming up with some embedded tests. So if you use a panel for dystonia, that is probably one of the main things that this talk here should trigger. Thank you. Make sure that your company, whatever you use, say, hey man, if you have dystonia, you ought to have ATP1, 2, and 3. 3 because the most common, 2 because it can be the zebra one. And it's easy for them to add that. So there's no reason for them not to add that because it's part of other panels. And for epilepsy, it's the other way. It's the same thing. I mean, you should, if you have a panel that you have this super, super rare 1 in 10 million encephalopathic epilepsy, you ought to have ATP1A3, which is 1 in a million. So that is rare, but not super, super rare. And so this is incumbent on you guys because you are the user. And so when you have a company that does your dystonia panel, you want to just go there, which is I usually go, and look in the panel. And the companies that we use, I usually look for that. So that should be in your seizure panel and dystonia panel.
There's a lot of reflexive exome sequencing going on in the adult world.
And so if you do exome sequence is awesome. And it's a trio thing, right? So as you know, exome is very hard to interpret if you do one person only. You got a lot of stuff that you're not sure what it is. So if you have 3 family members, not 2 family members, 2 other family members, it's great. And more and more university places are moving to that. I remember several years ago, there was somebody from CHOP saying that the muscle disorder people at CHOP, at Children's Hospital of Philadelphia, did a cost analysis. If you have a muscle disease and you do all tests A, B, C, D, or just exome at the door, the first time that they have a contact, whole exome was better diagnostic than doing all the rest, and then you select which children are really gonna really stick a needle and do an EMG. So they did, and I think this is becoming also good. There's a slight lesser density, meaning like the number of DNA strips that they use for every gene is a little less for the whole exome. But overall, it's decent sensitivity, so most of the times, very busy services are moving to that. For example, if you have two genes that you have to sequence, it's always, any company is cheaper to do whole exome. Like if I have somebody, we are TS center. And so if you do the TS genes, many times it's separate. And then you have to sequence and you say, oops, that's not TS, this is something else. You do the second one, you're already spending more time if you had done the whole exome at the door. And so you gotta be careful with not when you do single genes, because you can be imposing a lot of costs for the family, so, yeah. So yeah, thanks for bringing that up. That's a great question that becomes more and more of an issue, even though most places still use the panels first as convenience.
Marcio, what's your speculation on the alternating part of the hemiplegia? Why one side one time and another side another time?
I was hoping you're not going to ask that. But I don't think we know, man. I think that's the thing that always hit my head. I remember when I was a fellow in 1994, Greg Holmes was the head of pediatric epilepsy at Harvard, say, hey, go get this talk to those people. And I went there, and I was just a fellow, right? I was scratching my head. It's like, what am I going to say to those people about that? And here you go. I am on the physician board. I'm supposed to be one of the experts in the country. I still don't know why he goes from one place and the other one place. It's just like, I don't know, like, for example, benign Rolandic epilepsy is the same way. People sometimes have seizures from the left, sometimes seizures from the right, and when you see them alternating, you say, aha, this is benign Rolandic epilepsy, because sometimes you have seizure from the left, sometimes from the right, and it's a benign disorder. Yeah, I'm not sure if you know that very well.
Does it actually alternate, or is it just kind of random whether it goes right or left?
It's random.
It's random?
It's random.
Yeah.
The other thing that I don't know is why we have like that patient that I presented, the one that presented as a baby, I still follow him. It's like, when does he have a 4-limb attack? And when does he have just one side? Because I've had people with a very severe epilepsy that many times still like, well, I had a patient who died because of status, and she still went like one time here, and sometimes more, all 4 extremities. I had a patient who had that severe mutation, and it still alternated sometimes 4 limbs, because I always, in my mind, it was like, oh, it should be more hemiplegic if you're mild, and 4 limbs if it's very severe. But that's not true. Yeah.
I got this right. Sleep turns it off.
Yes.
When you wake back up, it's not like it turns back on and is back where you left it, right?
No, yeah.
It just resets it.
It's reset. It's the reset button.
There's got to be something in that pathway for arousal and sleep that just is
you and all the Jets fans and everybody in the world is like been looking for that, and nobody has found the reset. Why is that? That's kind of amazing. That's why many people like the gamma hydroxybutyrate, because this is it's whatever it's bad, it's whatever it's good. So the people use for date rape, because the bad guys know that makes people fall asleep fast. And that's why the police is like so nervous about it, because exactly that's this quality that we love it, which is like, oh, bang, the person falls asleep. And there's no trace of that after they wake up. And so people love that. In the olden days, when the American Academy of Pediatrics hadn't put chlorohydrate on the bad boy list, we used to use a lot of that. But since I came to America in 1988, very quickly, the American Academy was always bad-mouthing chlorohydrate and blah, blah, blah. We stopped using even for sedation, but people used to use a lot of that because chlorohydrate gets very quickly absorbed, and formaldehyde too. People used to use that. Same thing, it absorbs quick, sleep quick. People get up and like, ding, they're fine.
Marcio, do you currently follow families in the area with this disorder?
Yeah.
How many do you think you got?
Right now, I just have a few of my families kind of grew, and one of my patients died, but now I just have one, that 137. But I had over the years several. I had, even since I was a children's, I had several. So I'm just trying to partner with the people there, children, see if we can capture some of those people that got lost to follow up. But yeah, everybody in our group has like 10 or so, except for the people at Duke, Mohammed Nikari, who was my professor there at Boston Children's. He has a bunch, and a lot of people go to Duke. Duke is the biggest center in the United States. But yeah, everybody has personally just a few. Harvard has more because has a center that people used to do. So Kathy Swoboda used to see, and and everybody used to send patients for Kathy. And now the movement disorder, the adult movement disorder person is doing both the peds and adults there. So they have like 20, 40 people that they follow, plus another 100 or so that people send to them. But most centers have like 10, something like that. And that's what I had here, 10, 20 over the years. I'm not sure if you guys have RTP in your clinics, no?
Well, thank you very much, Marcio.
Oh, thank you.